wanted to introduce you all April, but you took the honor out of me. She's an amazing lady. She has so much passion that I've never seen anyone do so far. I'm really looking forward to see what you're going to show us because as Dr. Ziad well knows, doing a lecture in the in talking about occlusion is a very hard task. So
thank you. Brilliant. Thank you very much.
The mic is yours.
Brilliant. Thank you. I shall start sharing my screen. I think that should, can you see that now?
Yes.
Brilliant. Thank you. Brilliant. So today I'm going to talk to you about parafunctional habits and how they affect our treatment planning process when we're providing implants. And I'm also going to talk about how to make a stabilisation splint. So I'm Dr. April Scoley, studied in Sheffield. The reason I'm lucky enough to talk to you today is because I'm currently doing the Baird implant course, which I'm absolutely loving. Unfortunately, it's on pause at the moment, but hopefully you're going to get back to it soon. My special interest is in TMD and occlusion. Started when I did an SHO year in Wakefield, looked mainly at the sort of surgical management of it. But really where my knowledge progressed is when I did the Royal College of Surgeons diploma in restorative dentistry, where I met Stephen Davies, who I'm sure a few of you all heard of. He actually made me a stabilisation splint as I was a guinea pig on the course, and I saw firsthand the benefit of these. I used to clench my teeth quite a lot and have a lot of headaches, and then they went, which is brilliant. So this led me then to shadow Stephen and also work on the TND clinic in Manchester Dental Hospital. So here I saw that how amazing stabilisation splints were in treating myofascial pain particularly, and also how not many people know how to make them. So I thought it'd be a great skill to share with you guys today. Currently using this loads in private practice treating myofascial pain patients. So here's my lovely Baird family. Baird's been brilliant. It's brought together a lot of like-minded people who want to do the best for patients and also have evidence base behind their teaching. So I can't wait to see everyone again soon. So I'm going to talk about parafunctional habits and whether there's any evidence base behind that, linking that to failure of implants. Why implants are more affected by parafunctional activity than teeth, and how we can prevent failure, and then finally how to make a stabilisation splint. So parafunctional habits, their oral movement disorder can be clenching or bruxism or combined, and affects about 10% of the general population. The etiology is uncertain. Originally they thought that it was more to do with morphological discrepancies, so occlusal discrepancies. But now the movement is more towards pathophysiological things such as the sleep arousal response, and also linked to psychological and neurological conditions. So is there any evidence base behind parafunctional activity and whether this causes failure of implants? There isn't. There's very little clinical evidence, and that's because it's very difficult to clinically quantify the magnitude and the direction of the bite forces on when you're conducting research, as Coulthard, Esposito and Slater found in this paper. Despite this, anecdotal evidence and multiple case reports show that great caution should be exercised if you notice that a patient does have a parafunctional habit. And this is because it can lead to marginal bone loss or component failure. So why are implants more affected than teeth when it comes to parafunction? It's because their adaptive capability is significantly reduced for a number of reasons. Number one, there's no periodontal ligament. The way that this helps protect the tooth we get expansion of the periodontal ligament with occlusal overload, as you can see on this X-ray. So you get temporary hypermobility of that tooth, which actually protects the tooth from fracturing. We also get orthodontic movement of the teeth as well. There's also no nerves or blood supply within the implant. So nerves help teeth, and when you don't have the nerves, you get a reduction by 9 times in the tactile ability of the teeth, so that disturbs that feedback response. So you can put a lot more load through the teeth through implants. You also have no blood supply, and blood supply helps protect the teeth from noxious stimuli, including occlusal load. Another thing is that implants are a lot narrower than natural teeth. So you can see on this picture, natural molar teeth have a wide base and the roots are quite wide, whereas with implants, they're a lot narrower. So when the occlusal load is going through the long axis of the tooth, it's okay, but as soon as it goes slightly off there, you get shear stresses which concentrate right around that fulcrum point, which is the bone, the cortical bone there. So that means it leads to marginal bone loss. So with teeth, you tend to get a few warning signs. If you've got increased occlusal load, you'll get wear facets, you'll get hypermobility, temporary hypermobility, fremitus, and pain in the teeth. With implants, you don't get this. It just happens really quick, and it tends to be more catastrophic. So you can get loosening of the screw, breaking of the screw, component failure, and sometimes even implant avulsion. So how do we know they have a parafunctional habit? What I'd recommend is to do a full articulatory system exam on all patients that are coming in for implant assessments. So this is my pro forma that I use, which I'd be happy to send to everyone. It's actually done by Stephen Davis, but he doesn't mind me sharing it with you. You would look at the TMJ, we'd listen to it through a stethoscope, look at the range of motion, test the muscles of mastication, so palpatum temporalis and masseter muscle. With the lateral pterygoid, you can't actually palpate it, so I'm just going to show you a quick video of how to test the lateral pterygoid. It's something called the restricted movement test. So to test the lateral pterygoids, what we want to do is a restrictive movement test. So if I ask the patient to put your jaw to this side for me, that's great, and I'm going to put pressure against it, and you want them to put pressure against your hand. So support your head with this hand and really push here. So push against my hand for me. Any pain there at all? No. And if there was pain, then there'd be tension in the lateral pterygoid muscle. And then do the same on the other side for me. Any pain there at all? No. Great. And then we go on to look at the occlusion, static and dynamic occlusion, and finally look at wear and intraoral signs. So how do we know they have a current parafunctional habit? So after doing that, we see that they've got hypertrophic masseters, and what you need to do with the masseter muscle is palpate it with your finger and your thumb so you can feel how thick it is. And if they've got intraoral signs such as cheek ridging and tongue scalloping, then we know that it's likely that they are currently grinding the teeth. Another thing we need to look out for is tooth wear, obviously, or pathological tooth wear. So pathological tooth wear is when physiological tooth wear happens throughout our life. So if a patient turns up and has this when they're sort of 20, then it's pathological tooth wear because it's abnormal for their age. So, tooth wear or tooth surface loss associated with parafunctional habits are abfraction lesions, as you can see here, this wedge-shaped lesion, and also attrition, which is tooth-to-tooth wear. So monitoring this, we can obviously make a note in the notes saying whether it's generalised or localised, mild, moderate or severe, but we need something a bit more accurate if we're going to look at whether it's changing or not. So we don't know whether it is current wear or whether it's just historical. So we need to keep an eye on what's happening. So we can do this with the Smith and Knight tooth wear index, as shown here. Each buccal, lingual, occlusal and cervical surface is given a code of 1 to 4. I find it quite difficult to do because I think there's interruptive variation. So I think that, and also between appointments there's variation. So I'd say take photos, study models, or if you've got it, an intraoral scan. So stabilisation splints. They're found, so the reason why I think the best to use, particularly for implants, when you've got a known parafunctional activity, is because it distributes the load across the teeth. You're probably thinking, why don't I just use a soft bite splint? Well, or soft bite raising appliance. Well, what they tend to do is cause the patient to bite down more. They like the kind of squishy sensation of it. So gold standard is making a stabilisation splint. And this paper down here has shown that it does reduce the potential occlusal overload. It's a removable ideal occlusion, and that's an ideal occlusion on the tooth level and periodontium level, because you're getting those even distribution of forces through the posterior teeth and having anterior dynamic occlusion. It's ideal on that level, and it's also ideal for the articulatory system because you're providing the patient with centric occlusion in centric relation. So that means that their jaw is in the position where you get neuromuscular release. Use stabilisation splints. Most things that I use them for are treating myofascial pain. You can also use them, obviously, because it affects the control of bruxism, because it's something that protects the teeth. You can also use it to test if a patient is going to respond well to a change in occlusal vertical dimension. So if you're doing a full mouth rehabilitation, it's a great way of seeing whether they're going to cope with that well, because it is removable. It's also great when you've got patients with reduced periodontal support that are getting hypermobile teeth because of occlusal overload as well. It helps to splint them together. So features of ideal occlusion that we want to incorporate into our stabilisation splint is when centric occlusion occurs in centric relation, freedom in centric occlusion, and no posterior interferences. So the next slide is a video of how I get a patient in centric relation. So hopefully you can learn a little bit from this. Okay, so I'm just going to show you how to find centric relation first. So as we know, it's the most reproducible position, and where your jaw has got the perfect arc of closure. So I'm just going to put some pressure down here and roll your fingers down the lower border of the mandible. And I'm going to use my thumbs to just put some pressure around the canine area. This is my husband, so I'm going to say to the patient, just let your jaw drop open for me. That's perfect. Now you can see that there's no translation there. It's just perfect arc. And then I'm going to bring him together, and I'm going to say there'll be a tooth that contacts first. Raise your hand when that happens. Brilliant. So it's going to try that again because we want to make sure it's reproducible, make sure it's the same place. So again, roll your fingers down here, use your thumbs down here. Obviously wear gloves, this is my husband now. If you just let your jaw drop open again. And is that the same position? Mm-hmm. Brilliant. So I'll just show that. So if you just relax again. Is it contact in there? And then fully close. So you can see there that the slide is mainly vertical from centric relation to centric occlusion, and his first contact is the upper left 4 with the lower left 4. So when I said the first contact, I meant the first contact in centric relation, so the RCP, some people call it. It's good practice to actually note that down so that when the models are mounted in the lab, they know that they've got it in the right position. So how to record centric relations. So sometimes it is hard to get someone back in centric relations. So if you're struggling and they're a bit guarded, you can use something here that's called a deprogrammer from Dina. You can buy them from Prestige in the UK. Reline it with a bit of blue mousse and put it on the front teeth, and then get them to move around in forwards and backwards laterally for about a minute, and that deprograms them. And then getting them back in, put them, say, go back into the most back position that they can get into, and then record that position with blue mousse. Then take that out and join them up at the front with blue mousse. How I do it is with green stick, like on the picture on the right. I manipulate them in centric relation, like that video, and get them to tap into green stick, and then that just holds them in that position while I then record at the back, and then ask them to open a tiny amount before I then join those up. You also need a face for recording and upper and lower alternate impressions. So instructions for the lab. I've got a full instruction sheet which I can happily send to anyone, and my details will be at the end of what to give to the lab, because some labs do struggle with it because they haven't done it often enough. So it's just a really good step-by-step guide on what to do. What you want to ask for is equal posterior contacts in centric relation. We don't want any anterior contacts because that doesn't give you the freedom in centric occlusion that we want. And we want to see canine guidance on lateral excursions, and then on protrusion, we want to be contacting on the 2 central incisors. So when it comes to the fitting appointment, book plenty of time because it does take a long time. 45 minutes to an hour. You want to check first of all that it fits. You want a nice click. You don't want it to be too hard for the patient to get out because they won't wear it. And if that is the case, then just adjust it on the lingual aspect. That's usually where it gets a little bit undercut. If it's falling around, then reline it. A really good material to use is Bosworth trim. Make sure you Vaseline the teeth beforehand, and bring it out when it's sort of at the chewing gum stage. You don't want it to fully set because it'll stay in the mouth. It's very difficult to remove. I haven't done that yet though. We then want to look at the static occlusion. So gently manipulate the patient back in centric relation and tap using the best articulating paper is 40 microns from Bausch. You use it on both sides, gently get them to tap into that, and then adjust. When you're adjusting, don't just adjust that point, do it in the full width of the stabilization splint, because otherwise you'll adjust the full horizontal. So don't just go on one point, otherwise you'll introduce working side interferences and non-working side interferences. And then we go for the dynamic occlusion, get them to grind side to side and then forwards and backwards at the front. What we want to see are the lines just on the canines and at the front. If there are any lines at the back, the dots are fine because obviously that's the static occlusion, but if it continues into a line, then again we need to remove that, just like I said before. And that's what we want to finish with: equal posterior contacts and centric relation, canine guidance, protrusion on the central incisors, and then review the patient. So for myofascial pain patients, what you'll find is they'll come back at their review appointment and they'll say, well, it was really good to start off with, and then I start to get pain again. And that's because you're getting that neuromuscular release, and that actually changes the position of your TMJ. So then you need to keep balancing it. What I tend to do is review the patient for 3 months and once a month. If I find by that point that it hasn't needed to be balanced again and the pain's gone, then I'll start weaning them off. So the first week I'd do that one night, so they'll leave it out one night, the second week leave it out 2 nights, etc. If it's a patient you've just provided an implant for, I'd get them to wear it indefinitely to protect them if you think they've got a parafunctional habit. And Yeah, but for myofascial pain patients, you can wean them off, and the final review, if they've had 6 weeks with no pain, then they don't have to wear the splint anymore. What you'll find is the more you chat to patients about parafunctional activity, the more they'll become more aware of it themselves. And some of my patients will wear it when they're a bit stressed. They'll just pop it back in again, and because they're aware that they're going to start clenching or grinding the teeth at night. So there's my email address and my Instagram. I'd be happy to send anyone the full articulatory system exam and that sheet to send to labs that are a bit confused about how to do it.
Thank you so much, April. This was amazing. Step-by-step learning. Even in the morning, there were people asking properly how to do the centric relations. So thank you so much for preparing that even at home using your own.
Oh no, my own husband, poor guy. I'm sorry. I would wear gloves, obviously, but anyway.
Thank you. I'll give the mic to Dr. Ziad if he wants to ask you something.
Well done, April. That was really a good presentation.
Thank you.
Enjoyed it. Summarized a topic which is very difficult. I know exactly that it's very difficult to summarize it in such a short time. April, just two things, if you don't mind, just comments. First of all, regarding the signs of active bruxism, we don't consider tooth attrition as a sign of active bruxism. Mm-hmm. Because the patients might not, they maybe used to have like bruxism before they had tooth wear, but now maybe they're not doing it. You see what I mean? So
yeah,
I'll agree with you with the soft tissues, the tongue scalloping and cheek ridging, absolutely. The other thing is regarding technique of centric relation. First of all, was you were on the not using gloves, but you I think you just heard that's very quick when you say that it's your husband that so I'll let you go away with this. The second point regarding centric relation is when you put the patient in supine position, the first thing actually do chin up, always focus on chin up for the patient in order to get the jaw relaxed. The other thing is the position of the thumbs, as you remember from the course, and you were the winner of the course. I remember. So the thumbs should be ideally not on the lips; it should be on the symphysis, and then you will expose the lips later on when you get the RCP, the first contact in centric relation. But pushing the lips with the thumbs down as a start, it might actually annoy the patient and you're not be able to get a relaxed position. So I would focus on the position of the thumbs on the symphysis. It doesn't need actually for the thumbs to touch each other, but you're just opposing each other on the symphysis. But again, well done. That was really a great presentation. Well done.
Thank you very much. Yeah. Probably I'm with the tooth where I probably linked it too much to current parafunctional habit, but I should have said that more. It's not a sign of a current parafunctional habit. So thank you.
April, I should say, sorry, April myself came from the same school from Manchester. I worked with Stephen for about 5 years.
He's brilliant, isn't he?
I have maybe about more than 10 publications with Stephen Davis and Robin Gray. So.
Yeah, I've seen your name on quite a few.
So well done. Pass my best regards to him if you
I will do. Thank you.